All right. So today, we're going to be talking about CQI actually from the last 2 months. So, October, November, in terms of cases, and we're going to go through several different cases. We're going to talk about some trauma, some pediatric mental behavioral health emergencies, some about arrhythmias, and then kind of one just random interesting case. Again, I'm Alex, one of the EMS fellows. All right, so we'll start by talking about a couple of cases of trauma, and as we'll go through, I'll kind of talk about what we're going to highlight. So this was a 66-year-old man who had fallen down a flight of stairs. He thinks he fell approximately down 13 wooden steps onto a basement floor. He was found at the bottom of the steps and was alert and stated that his left wrist and right knee were hurting him. He also had a very large laceration skin flap over his forehead with visible skull. It was bleeding a lot, so the medical crew quickly wrapped the laceration with trauma dressings and gauze wraps. Left wrist and right knee were air splinted in a position of comfort. Patient stated that he did not have any neck or back pain, also stated that he did not lose consciousness and doesn't remember how or why he fell down the stairs. So that's always an interesting story, right? I didn't pass out, but I have no idea what happened. Always makes me question. And then the patient had a medical history of brain cancer, for which he's in remission. Stated that he felt fine before the fall, but does not remember the fall or why he was at the top of the steps. The patient stated that he is not on blood thinners, and his only complaint at that time was his left wrist and right knee. His alert and oriented ×4 with a GCS of 15. Patient's back was swept and found no abnormalities. He was moved to the stretcher, refused fentanyl, but did say yes to ketamine. So he got a 20 gauge IV, gave 50 milligrams of IM ketamine, and the bleeding from the head was mostly controlled, but they did note pretty significant blood loss at the scene. Trauma alert was called and oral report was given. While being transported, the patient's clothes were cut away and didn't notice any other injuries, had good pulses in all of his extremities, and got some IV fluids. His vitals were a blood pressure of 140/97, heart rate of 98, respiratory rate of 24, and 97% in room air. So I think this case highlights the March algorithm, which hopefully everyone has heard of at this point, but this is sort of our systematic approach to traumatic injuries. So what I think was done really well in this case is that first M, so finding and stopping sources of massive hemorrhage when you can. So gigantic head flap wound is obviously there, it's in your face. You can see it when you just look at the patient, obviously unless they're face down, but they addressed that and did a good job of reassessing kind of bleeding from that wound, and then also documented that they kind of swept for everything else and tried to make sure that there weren't other sources of bleeding. And then the remainder of these, airway, respiration, circulation, were not really an issue in this case, but I did want to kind of bring this up just as an example of going through the March algorithm. I'm gonna be recording a discussion about kind of geriatric care for you guys. This patient was 66, so technically fits in that geriatric bucket, whether or not we like to think that of ourselves or not. But these patients are at higher risk for bony injuries as a result of sort of the normal processes of aging. There may be other medical issues at play as to kind of why these patients fall. So a fall is not only necessarily mechanical for, yeah, sure. Not necessarily only mechanical for our geriatric patients, but we have to think about medical causes as well. So a couple of things that I think could have been considered in this case is we didn't get or document a blood glucose level, right? Could this patient have been hypoglycemic and kind of woozy, and that's why he fell? Obviously not totally altered by the time you guys got there, which is good. I think that's one consideration. And the other is an EKG, right? This patient has a complicated cancer history, probably has at some point in his life been on a sort of complex medication routine and stuff. And so an EKG may have been helpful just to identify and make sure that there wasn't a cardiac reason for why he had fallen. And then the final thing is, when I first ran through this case, I was pretty concerned that the patient wasn't immobilized given his age and the mechanism, just because it's not in the narrative, but it was actually in kind of like the documentation of the different procedures that were performed. So just so that you guys are aware, if we tend to look through the narratives as our quick screen, and so didn't catch it in there, but it was actually documented in the procedures. So appropriately immobilized in this case, just remember to think about that and do that. And if you can, make sure that you're documenting all the interventions that you're doing. So that's that patient. The next one is a 70-year-old female who was one of the drivers with front end damage with airbag deployment, just ANOR ×3, breathing 18 times a minute and regular, has an obvious left ankle fracture or deformity, obvious left tip fib fracture deformity, and left wrist fracture deformity, so multiple extremity injuries. The engine crew stated that she did not have any neck or back pain and didn't have any pain on palpation. Got 100 mics of fentanyl, actually with the first crew that had arrived, and then they were moving the patient. Vitals were a blood pressure of 135/67, a heart rate of 76, respiratory rate of 18, and 97% in room air. On assessment by the medics, patient's alert and oriented ×3, no injuries noted to the head, doesn't complain of any pain there, had no loss of consciousness, eyes are fine, breathing's fine. They cut the patient's clothing and found those obvious fractures or deformities in there. They asked again to and so at the end, they did not apply a C-collar to the patient.
I'm thinking about it. There.
And then they did splint the extremities. So I'm gonna go back again, sorry. So did splint the left leg, and the left arm rechecked PMS after that. So that was really well documented. So this is a case that I want to talk a little bit more kind of in detail about the spinal motion restriction part of your guys' protocol and C-spine mobilization. So when you get to this protocol, basically you're running down this left side. A yes to any of these questions means that patient needs a C-collar. Obviously, I think the way that it's documented, and all I see is documentation. I wasn't there on the scene, so there's a lot going on here, especially there's a second patient that was still being extricated and all this sort of stuff. So obviously taking that for what it's worth, but for this patient, clearly the folks on scene thought critically about whether or not to apply a C-collar and reassess the patient frequently. So there are multiple times documented where people, felt and checked her neck. And then sort of in the end, she said that she didn't want one or didn't feel like she needed one. And I would argue that this patient, unless they're blatantly refusing and you don't want to document that you said I'm doing this and they absolutely refused, that this patient definitely should have a C-collar. GCS is fine, no tenderness, no focal neurodeficits, not intoxicated, but this question of distracting pain, documented multiple areas with obvious deformities in terms of two parts of the lower extremity and that upper extremity, all with obvious deformities. And then this patient also kind of continued to ask questions and worry about the person who was driving with them and what was happening with them. That person is not paying attention to their own physical state, and they may not be able to really adequately assess, do they have pain in a certain location? So I would argue that this patient definitely should have had a C-collar. And it's, just about the way that you document the conversation and the way that you have that conversation, really. So, this is what we're doing. This is why we have to do it. If they're swatting at you or blatantly refusing or can't cooperate when you do it, then document those things. But in terms of the medical care, that's the one thing that I would have changed about this case. All right, so we're going to move from kind of C-spine stuff to actually penetrating trauma. So this was a 73-year-old dispatch, was actually just for an unconscious patient in the front seat of the driveway. And what folks found when they got there was certainly a bit more. So patient was found in the front seat of a minivan with her head down, semi-conscious, pale, cool, diaphoretic, slightly ashen, GCS of 5, responding to painful stim. Once they started getting vitals, she was tachycardic with a SAT of 85%. Rapid trauma assessment was utilized due to seeing blood below the waistband. So that's fantastic. And the medic noted small venous bleeds with bruising around small wounds indicative of cavitation and gunshot wounds ×6. No exit wounds were found. Looks like there were 6 shots, basically up and down the left side of the chest and upper abdomen. The patient was known to be on blood thinners, but there wasn't much external bleeding, so there was a significant concern that there was internal bleeding. Initial vitals were a blood pressure of 88/60, a heart rate of 118, a respiratory rate of 8, and SATs of 80 in room air. So these are pretty awful vital signs with hypotension, tachycardia, depressed respiratory drive, and hypoxia, right? So this patient's got every kind of checkbox in terms of signs and concern for hemorrhagic shock, certainly in the context of penetrating trauma to the chest and abdomen. Patient got placed on a non-rebreather at 15 liters with capno. Breathing began to be labored, but it looked like she was still compensating, still had sinus tach on the monitor. There was a discussion about the decision not to decompress the chest, but they did bag the patient once kind of that continued depressed respiratory drive was noted. Got an IO in the right tibia because there wasn't any other way to get IV access. Drew up TXA, gave the TXA, and this seemed to maintain her blood pressure. There's good compliance with the bagging without needing a nasopharyngeal or pharyngeal airway adjunct. And there's good documentation of assessing lung sounds, especially due to the pattern of the gunshot wounds over that left chest and left abdomen. But they did not sound diminished. There was no tracheal deviation, no muffled heart tones, no JVD. The patient was given warm packs to treat for the shock and prevent a hypothermic reaction, and the patient was blanketed. So this is really a kind of discussion about hemorrhagic shock in penetrating trauma. So I think the keys here were obviously vital signs that we talked about from the start being indicative of shock, the note that the patient was on blood thinners, and then in particular the pattern of gunshot wounds. So this is sort of a summary of the protocol, but basically management of hemorrhagic shock starts with aggressively managing the airway, considering intubation if the patient will tolerate it. Looks like this patient was kind of going between a GCS of 5 and 8 maybe, and so may or may not have been able to tolerate it without meds. If she had started deteriorating, then I definitely would have considered intubation. Trying to identify and treat life threats in terms of the respiratory system, controlling any external bleeding, limiting scene time, transporting quickly, and then getting 2 points of access whenever you can, starting fluid boluses, and if there's no response to the fluid resuscitation, then thinking about tension pneumo as a possible cause. And remembering also that once we start bagging or ventilating a patient, that we can actually worsen a pneumothorax, right? That pneumothorax is that little kind of burst area in the lung. Well, when it's a gunshot wound, it's been ripped through, but the lung tissue is torn, and air is escaping out of the lung and collecting on the outside of the lung. And so every time we bag a breath into that, we push more air into the lung, but then also out into that pneumothorax. So bagging can actually make a pneumothorax worse in these patients. So there's a couple of things here. I think there was an obvious kind of oozing from the wounds. I think there's great documentation that the patient was checked all over for exit wounds and other injuries. So that's the first thing. Certainly, if anything had been bleeding, just have someone hold pressure with gauze whenever you can. Going back to that March algorithm, dealing with massive hemorrhage is step one. When it comes to the respiratory assessment in this patient, I think it would have been absolutely reasonable to needle this patient's chest, right? You have obvious penetrating wounds to the left side of the thorax. The assessment is good in terms of paying attention to lung sounds, looking at everything. The medic looked and searched for all these other signs of pneumothorax and tension pneumothorax. But a patient who's hypoxic, hypotensive, tachycardic, even if your exam is reassuring, when you got obvious holes in the side of the chest, I would lean on just go ahead and needle. It's a simple procedure. It's a quick procedure. It's relatively non-invasive. And if you can clear some of the pneumothorax there, then that may help you. Obviously, this patient likely has hemothorax as well with blood in the chest. But being able to clear some of that air may actually have helped that shock state a little bit, especially once the patient needed bagging, and that could worsen a pneumothorax. Other things in this, IV access was a challenge. If you got to go to IOs, absolutely fine. You got 6 options. So if you would normally think 2 large bore IVs, you can't get 1, go ahead with 2 IOs, right? Do a humerus and a tib, do both tibias, do both humeruses, whatever you need to, right? But you can get 2 points of access any other way as well. So in addition to the TXA, a second point with some fluids may have been helpful. I don't know if we have follow-up on this patient. What happened to her?
No, don't have that one.
Okay, cool. So those are the sort of things to consider with this case. Thinking about needle decompression, these are the 2 places that you can decompress. Dr. Richards can correct me if I'm wrong, but from a medical direction standpoint, these are equivalent to me. I would say go where you are most comfortable, go where you have access to the patient. And if it clots off, feel free to go again right next door to it in the same area, or switch to the other landmarks. So your first option is second intercostal space, midclavicular line, right? That's your standard kind of placement. And what we've moved to in ATLS is that 5th intercostal space in the anterior axillary line. And the best landmarks for that are basically the nipple, or where the nipple should be in a female patient, and that anterior axillary line. And that's usually about 4 finger breadths. So if you kind of stick your hand in the armpit, 4 finger breadths at where your thumb lines up with the armpit is a good spot to go. So from my perspective, either of those is fine. Both will work, but either one may clot off. So if it stops working, feel free to repeat the decompression right next to it. Dr. Richards, do you have anything else to add in terms of the trauma patients?
No, I don't. I couldn't come off mute in time, but from a follow-up perspective, she did end up with a splenectomy. But medically speaking, actually did pretty well. She got discharged to inpatient psychiatry and then subsequently discharged from there. So, nice job kind of doing the stabilization efforts. I agree with your point about if there's holes in the chest, it's almost certainly she's going to end up with a chest tube in that situation anyway. But in terms of needle decompression side, I do tend to prefer kind of like the anterior axillary line approach, but I feel pretty confident with the mid-clavicular second. So that is a reasonable option as well.
Yeah, I think certainly in hospital, we're moving to more of like that lateral chest wall at the anterior axillary line. Again, the biggest thing with that, sort of the biggest risk with that one is if you go too low. So doing that 4 finger breaths underneath the armpit, or paying attention to where the nipple line is, or again, should be in your female patients, then that's where you want to go. All right. You guys didn't have me for a couple months, and I'm back, so we're going to talk about some pediatric topics. So the next couple of patients that we're going to talk about and protocol that we're going to talk about is pediatric agitation. So I'm going to do this one a little bit backwards so that we can think through the cases a little bit more critically. So we'll start with what the protocol says and why, and then we'll talk about a couple of cases and kind of review through what we did and maybe what we could have done differently. So when it comes to pediatric psychiatric emergencies, the biggest, most important message is that your safety is of the utmost importance and the patient's safety is of the utmost importance, right? So these protocols are in place to keep our patients safe, but also to keep you all safe while you're managing them, because it obviously, you know, there are some 13, 14-year-olds out there that are bigger than me, right? Like they can certainly hurt you if we don't manage them carefully. So we want to keep you guys safe. Remembering that restraints are only to be used for medical purposes, or if a patient is violent or a danger to themselves. So if you have to restrain someone because you absolutely need to get an IV and give meds, maybe to a trauma patient who has head trauma and is combative and altered and that sort of stuff, then that's your medical indication. Right now. And then although psychiatric emergencies obviously are common and you guys have a couple of spots that you respond to that you know are probably going to be psychiatric, just remember that there are medical conditions that can make patients combative. So stroke, intoxication, head trauma, hypoxia, hypoglycemia, shock. These are all important medical conditions that may lead to altered mental status or aggression or combativeness. So in terms of the protocol, a sort of overarching principle of restraints is using your least restrictive means possible. So that starts with verbal de-escalation. We'll see a case where that was done really well. Next is physical restraint. So the things about physical restraints is that you have to be able to get them off quickly if you need to. They cannot compromise airway, breathing, or circulation, and you need to be able to adequately monitor the patient, right? So patient needs to be laying face up. The restraints need to be soft restraints that you can remove if you needed to in an emergency, and you got to get access to, you know, vital body parts and be closely monitoring that patient. And then the step up from that is chemical restraint. So this is any patient who continues to be a danger to themselves despite the physical restraints, or who is presenting an extreme danger while in physical restraints. And the medication in the pediatric protocol is Versed, either IV or IO, or more likely in a situation where someone's being combative is intranasal or intramuscular. So, yeah. You guys all know that Versed causes respiratory depression, so absolutely needs close monitoring, particularly of airway and breathing, checking your blood glucose, because that would be an easy fix if that was the reason why this person was actually combative. And if you need repeat doses of Versed, then that's a conversation with online medical control. So again, start with verbal de-escalation. If you have to progress, you can progress down. Your safety and the patient's safety are what we're trying to ensure with using this protocol. And then the dose for pediatric patients, this is taken from the end of the Southwest Ohio protocol. So you have all of the pediatric doses by age or weight. We're going to see a couple of cases of like 8 or 9-year-olds. So for that patient, the appropriate intranasal or intramuscular dose would be 5 milligrams. And that is higher than the IV or IO dose. So just remember that if you're giving this, depending on the route, that your dose is going to be different. And really, in the case of agitation, we would veer on preferring intramuscular Versed. It acts faster, it's got better data for its effect in terms of the treatment of agitation. And you're not gonna, yes, there's a needle, and you're gonna need people to make sure that you guys are safe with that needle. But for intranasal, you know, the patient can blow out their nose, spit at you, all that sort of stuff. And we don't know definitively that it works as well as intramuscular. So that's what we would kind of lean towards when it came to Versed. And then the final part of the protocol, which is the most annoying and tedious part, but actually folks did a great job with this, with these cases, is documenting the restraints. These rules are the same for me in the hospital as they are for you guys. So yes, it's a bit of a pain. Yes, it's a lot of rules. I mean, it's a ridiculously long slide, right? It's a lot of rules to follow if we're going to restrain a patient. But these are all in place to make sure that we're doing this ethically, properly, appropriately, and that we're adequately monitoring our patients. So these are basically the check boxes that you have to go through if you're gonna, even mentally, if you're gonna restrain a patient in terms of documenting that. So there was an emergency, that's why I did it. The patient refused treatment or couldn't consent to treatment or is incompetent and not able to refuse. The less restrictive methods failed. There was the assistance of law enforcement on the scene. The treatment was for the patient's benefit and for their safety. What kind of restraints, what limbs were restrained, any injuries related to applying or using the restraints, making sure you check circulation every 15 minutes, and then the patient's behavior or mental status before and after the restraint. So a lot of things to make sure that you think about, but all of these really honestly are things that we should be paying attention to when we're considering restraining a patient. All right. So as promised, these are the cases. So the first case, this is a dispatch for a psychiatric patient, arrived on the scene for an 8-year-old, being combative, refusing to be treated. Patient was alert and oriented with GCS of 15 and a history kind of these episodes. Patient spoke to EMS alone, which I think is fantastic, and revealed that the cause of the situation was stemming from a bullying issue that had occurred. Patient was able to calm down. We did not get vitals due to not wanting to work him up, sort of back out of that calm state. But there's a couple of things that were noted. Patient had normal skin tone, slightly tachypnic because of the tantrum, and the mother was on scene, stated that she had dealt with the situation, was aware that transport was an option. Again, it was offered, but she wanted to transport the patient herself, and that conversation's documented there. So this is a great example of some of the kind of tools for verbal de-escalation. Having police on scene, it can be very, very helpful. And it can not be very, very helpful, as you guys probably know, right? Like when they're there and they help keep everyone safe, that's great. But when the police are there and it's a 8, 10, 14-year-old who now the cops are involved with the situation, it can just escalate things. So we need their help. We appreciate their help when we have it. But the fact that this provider took the patient aside, kind of got the story from them themselves, was able to calm them down, is an example of sort of the work that you guys can do outside of having law enforcement being present. So I think getting the patient alone was fantastic. And then they did document a little bit of the exam. I would say 80% of my pediatric physical exam is observation. So you can get almost everything you need to without putting monitors on a patient, right? Pretty much everything except a pulse ox. So if you can hold their hand, you can check their pulse. You can check their perfusion. You can count their breathing. So there are other kind of components to the physical exam that can be done without needing to be kind of like in that patient's face and escalating them further. And one of the other cases has a really good, has some good documentation of that. But I did think this was a good example of using verbal de-escalation as your first tool for a pediatric patient who's being aggressive. All right. These are all very, very similar cases, so I know that you guys are familiar with them. So this is an 8-year-old Beckett Springs. Everyone is there when the medic crew arrives and is talking to the patient. The mom says that the patient's been having a severe temper tantrum related to violent hallucinations, resulting in combative behavior, was in a therapy session, had an outburst, and did not respond to verbal counseling. So that's why they called you. Due to their combativeness, we weren't able to get all the information, like, initial vitals, but the patient is alert and oriented ×4, GCS of 15, open and intact airway, breath sounds clear bilaterally, symmetric chest rise and fall, skin is warm, pink and dry, can't get a blood pressure. This is what the patient was doing. They were biting, spitting, kicking, scratching, everyone involved in their care, but eyes are fine, PMS is good, right? So this, I think, is a fantastic description of what's happening and a really good exam, right? Like you get a sense of the patient's neurologic status, you get a sense that sort of like core vital functions are fine, even though you can't get vital signs, or sort of like a complete set of vital signs. And you also describe the behavior that this patient is engaging in, and why you then go on to give medication. So patient got intranasal Versed after 10 minutes without behavior changed, and was placed in soft restraints during transport. The patient became combative again, and another dose of intranasal Versed was administered. And at the hospital, they still needed your help in terms of getting the patient in soft restraints. So the kind of thing I wanted to touch on with this case is sort of that the dosing of intranasal Versed and when we need to chat with medical control. Intranasal is a fine way to give the medication. This patient got 2 doses of 3.5 milligrams. So each individual dose a little subtherapeutic, and giving it intranasal may have been part of the reason why they didn't see an effect. And so I would advocate for you guys to, if it's safe, go ahead and do intramuscular, reference that dosing chart so you know what you can give the patient, and hopefully you'll see a better effect. And then the second thing is for the pediatric protocol, which is kids 18 is 8, so definitely fits in the pediatric agitation protocol. If you're needing a second dose, then it really should be a conversation with medical control about getting approval for that dose. Because in the end, this patient got a total of 7 milligrams, which is above, what should be the initial dose. And so as you escalate in terms of the doses, obviously your risk of adverse effects, particularly depressing their respiratory drive and needing to support their breathing, you get, the risk of that goes up. So those are the things to consider with this case. But I think the documentation of what they were able to get, even just from observing the patient and sort of like gently laying hands on the patient, was really good. All right, the final one, 9-year-old, I think this patient was also at Beckett Springs, who has been saying that she wanted to kill herself and everyone else around her. Found on the floor with nursing staff and her dad. The patient has an extensive behavioral history, and only acts like this when she's forced to go to school, has had flare-ups in the past and needed to have medication to relax her. So I think this history is helpful, especially coming from the father and not just, staff who may or may not know this patient as well. If you're getting a history like this, I would caution you to try not to anchor on the information you're seeing, right? Just because a patient has needed medications to de-escalate in the past doesn't necessarily mean they're going to need them today. It's certainly, when we look at the data, patients who have a history of escalation are more likely to escalate again. And so you need to be aware of that. But, having gotten these stories myself and gotten them from tradies and stuff as well, just make sure you're still keeping an open mind when you get a history like that. But regardless, after having said all that, the staff and crew attempted to move the patient, but the patient was kicking, punching, and screaming, saying she hated all of us, wanted to kill us, wanted to die and kill herself, and was secured to the cot. She was put in soft restraints, but she was trying to strike her head on any surface and was trying to claw at anyone in reach. And all verbal attempts to de-escalate the patient had failed, so they did move to giving 5 milligrams of intramuscular Versed. And the patient appeared to relax, but was still kind of pulling away. So this is an example, again, very clear indication. I have absolutely no problem with the indication to give the Versed in this case. This patient was not keeping herself or any of the providers safe. And then the dosing and routes are perfect. Once she calmed down and they could do some sort of kind of monitoring, the patient was placed on nasal cannula and capno, and didn't seem that she had injured herself or had any complications from being in the restraints. So again, good use of medication and use of the medication according to the protocol. Be thoughtful when you're getting these histories and just keep an open mind, and do your best to kind of check any bias at the door and go in with as much compassion as you can for these patients. But if you or they are at risk, then you have this as your fallback. Dr. Richards, do you want to add anything else to that discussion?
No, I don't think I have anything else to add. I mean, it's a tough situation that everyone finds themselves when these things happen, but I think these cases really kind of highlight, good protocol driven, crossing T's, dotting I's, compassion for the patient, family. I guess a consideration I might have for you, better to them to maybe comment on, which was not really any part of this, but if you kind of start getting into like, I don't know, discrepant histories or concerns of abuse, like in these situations, like where do you kind of suss that out a little bit? Let's say like something like this happened at home and the kid's kind of saying, well, I'm getting, you know, bullied by my stepdad or something. I don't know. Like where does that kind of come into this conversation, do you think?
I would say anything that a patient says, we track down. I've had plenty of parents say like, well, every time I bring them to the hospital, they start telling people that I'm hitting them. Well, that might be true, and you may not be hitting your kid, and it might just be their defense mechanism, maybe, or maybe you're hitting your kid, right? And what is the higher risk situation? The higher risk situation is that this kid is being abused or being hurt in some way. And so we track down, and report any of those sorts of things. In our role as mandated reporters, you do not need proof of anything happening. All you need is suspicion. And so it's not necessarily something that I would say you guys absolutely would have to report to the state, but it is something that once they're here, if that was said to you on scene, we would like to know about it. And our social workers would follow up with the patient, would have individual conversations with the patient and the family members, and likely end up reporting. And then it's up to the state kind of where it goes from there. But I would say, believe your patients, and it's not your job to do the detective work. There's detectives to do the detective work, and our job is the medical care. Yeah, it's a good question. And it can be hard to tease apart, and the sort of like worst, most depressing thing, right, is that we miss cases of abuse. And that may be why the patient is sad or hurting themselves. So we gotta think about it. All right. We're going to go from there to talk about a couple of cases of arrhythmias, and then one final kind of brief discussion just about what I thought was an interesting case. So this first one, this was a 65-year-old male with chest pain, complained of feeling weak and off, has diabetes, had an angiogram sometime in the past that showed a 70% blockage, but they didn't feel like fixing it then. So today, now he's in your care, congratulations. Patient started feeling weak and just not himself. On arrival, good mental status, GCS 15, good perfusion, equal pupils, clear lung sounds. Vitals were obtained, blood pressure of 188/82, heart rate of 102, so hypertensive, tachycardic, respiratory rate of 16, and sats of 96% on room air. Blood glucose was 120. And then where he was sitting, got a 12 EKG that showed AFib, which was totally new for this patient. So the medic got an IV started, gave aspirin, and brought him in. For this case, I don't have access to your guys' EKGs, so I'm going to trust you that this was AFib. You're probably better at looking at EKGs than I am. But I will say that I think giving the aspirin in this case was a very good idea, right? So new onset arrhythmias can be acute coronary syndrome. This patient has bad coronary artery disease. And so this new AFib can do one of two things. Either he's been in AFib for a while and that's kind of shot off a clot that has actually caused an MI, and that's really the source of his chest pain. Or an MI is the reason for kind of some changes to that conducting system that now has put that patient into AFib. So in either situation, when it's new, the patient has chest pain, with these abnormal vitals, I think the aspirin was a good idea. Because certainly some sort of acute coronary syndrome is on the differential for what might be going on for this patient. Did this one come to?
Yeah, is that the one I sent you the in-hospital EKGs for?
I did not see those.
Oh,
Yeah.
I sent you that.
Meetings all morning and then this. Do you want to look at it and then?
Yeah.
Tell us after, okay. This is 256 is the end of the case number. All right, second case, very similar sort of situation, so. Oh, no, sorry, actually, I skipped the second date of the case just to do something different. So this is a 35-year-old female with palpitations, started feeling her heart racing, and said it was 161. She has a history of palpitations. Normally it's controlled, clearly not controlled today. She's sitting on the chair in the front porch, alert and oriented, airway is patent, but she's breathing a little fast, rapid, and her skin is pale, warm and dry. She said the palpitations have been going on for about an hour and complains of belly pain across the entire lower abdomen and radiating to her back. Normally that she has this pain due to endometriosis, and it's been this way for the last month. But she is feeling now nauseous and just threw up. Patient takes it, she took her temperature and it was 101. She's got good PMS in all extremities, able to step off the porch and sit on the cot. The 4 leads, so just on the monitor, has sinus arrhythmia from 140s to 68. I don't know if that's 168. And got an IV in the left hand, got Sofran, blood sugar measurement was 138. And vitals were a blood pressure of 159/73, heart rate of 131, respiratory rate of 22, and 98% on room air. So this patient, sort of the summary of this case is that she didn't get a formal 12-lead EKG. And I really think that she should have. So young woman with a history of palpitations, with grossly abnormal vital signs, right? Hypertensive with a wide pulse pressure, heart rate of 131, kind of pale, not looking perfect on exam. And you can't actually tell definitively that this is sinus arrhythmia from the monitor and the 4 lead. So I think this patient definitely should have had an EKG, and possible she wanted to go to Christ, I think. So she went to Christ Liberty, if I'm remembering correctly. But had she had, something where a certain level of care or a certain institution would have been appropriate for her, then you would have wanted to know that. So really low threshold to get an EKG, especially in anyone with a cardiac history and abnormal vital signs like these.
So your previous patient?
Yeah.
Just looks like they were just managed for hypertension, including the buzzing in their hands. They related to hypertension.
Yeah.
Remained inpatient for just a little bit and was discharged.
Okay. So no, didn't go to the cath lab.
Nope.
Like that. Cool. And that's absolutely fine. Again, I think it's the aspirin did not hurt in this first case, and could have been helpful. All right. The third case is a patient who has a history of SVT, and on arrival, the engine crew had already gotten an EKG and they said it was SVT, which is great. They were sitting in their chair, conscious, alert and oriented. They started feeling sick like earlier in that morning, denied chest pain, was able to walk to the cot, got an IV, gave oxygen, and kept the patient on Capno. They attempted vagal maneuvers, which were not successful, then gave 6 milligrams of adenosine through that left IV, temporary decrease in rate, but not sustained, then gave 12 with a similar result and another 12, but the patient never had sustained conversion to sinus rhythm. The vitals in this patient started out with a blood pressure of 113/60, but the last vitals taken were actually a blood pressure of 99/60. Heart rate was pretty consistent at 197, respiratory rate of 18 and 94% in room air. So this case highlights kind of the appropriate marching through the algorithm for SVT. So for a stable patient who's got decent perfusion, you're gonna, and actually that was the pediatric protocol, so I'll just stay here. You're gonna start with vagal maneuvers. So bearing down like you're trying to go to the bathroom, kind of blowing out while you're kind of sucking on your thumb, blowing into a syringe. Those are all different ways that you can try and get a patient to vagal. For kids, you can do, if you have access to it in the home, you can do ice to the face. If you do that, it's not like a gentle sort of like patting of the forehead. You really want to like put that ice and hold it over basically above their nose and over their eyes without suffocating the patient, but it's got to be quick and swift. So if you're gonna do ice to the face, that's the way to do it. And if those vagal maneuvers don't succeed, then moving on to adenosine with the 6 and 12 and 12. I wanted to remind you guys of kind of strategies for giving the adenosine. So usually, you know, left side is going to be your easiest place to access an IV. But if you're able to get one in the right AC, it's a little bit closer to the venous drainage of the heart, and adenosine has such a short half-life that in pediatric patients, I find it makes a difference. I'm not sure if it would, but if it's not working, you could try for another point of access on the right side. And then it really is a quick push and a quick flush. So we'll see if this wants to work. I don't have high hopes. That's having a little seizure. Oh, no, I broke it. What's that? Not the first person to break it.
Like it's fitting.
Okay, go. Okay, so I'll just keep it here so that the picture is a little bit clearer. So couple of options for what you can do with adenosine. It is faster if you use a 3-way stopcock to do that push and flush. Do you guys routinely use 3-way stopcocks to give your adenosine? Or usually give it and then disconnect it and then flush again? So if you are comfortable with the 3-way stopcock, you can do a couple of different things. If it's just one of you, you can have the med connected to one of the ports and the flush connected to the other. Just hold the flush steady, give the med, and then push the flush with all 3 parts of the stopcock open. Or if you have a second person, you can actually move the kind of like that trigger of the stopcock to have it so that the med goes in, then quickly move it and then give the flush. But it saves you a little bit of time in terms of actually getting that med in. Again, for pediatric patients where you're using low volumes of the medication, this really, really helps. For adults, maybe less helpful, but adenosine lasts seconds in the body. So you really need to get it in quickly and flush it really super, super fast. So there are videos online about different ways to do that. All right, so the final case, which I thought was worth discussion, mostly because I think there was a lot of discussion on the scene based on the documentation, is this case of a woman who delivered at home. So there are multiple units on scene for this. This is the documentation about the care for the baby. I was not able to see the documentation for the care for the mom, but dispatched for a woman with imminent delivery. The medic crew who was there for mom requested a second medic crew to transport the newborn because they felt like the mom was not doing well after birth. Other team members on the scene said, you know, maybe we should just keep the newborn with the mother. But the medic crew who was caring for the mother were concerned that really she wasn't doing well enough to keep the baby with her. In terms of the baby, APGAR score was 10, had good color, was active with a good cry. Also noted that the baby had already tried to breastfeed since delivery. After 5 minutes, repeat APGAR score was 5 again, and the medic crew transporting the baby followed the crew transporting mom emergently to Westchester. During the transport, the baby was reassessed, was warm and pink, cap refill less than 2 seconds, lungs sounded good, respiratory rate of 34, heart sounded normal with a rate of 115. And the squad kept the ambulance very warm for the patient during this assessment. So, couple of things about the baby, because again, you got me talking to you, unfortunately, but really there was more documentation than this. I kind of cut it down, but multiple times where it was noted like that the baby was kept wrapped and warm. If you guys may only have a sheet with you on the medic unit, feel free to take a towel from the patient's house, right? Whatever that baby got born onto is going to be wet and sticky, and is not going to be as good as a new dry sheet, a new dry blanket. So if they've got a fleece, if they've got some blankets, if they got some more sheets, because you may not have that many options for you actually in the squad, absolutely grab those, and just remember to change it out from whatever the baby was originally in, because staying in those wet sheets can cool them off even if you're doing everything else you can to keep them warm. If they have a hat, great, but not the source of the emergency in the situation. And then really good job documenting like continual reassessment, right? Like this is a fresh newborn, anything can happen. And I thought that was really well done in this case. A reminder of kind of assessing newborns. I follow kind of what's here on the left to tell me like, do I need to intervene or not, right? So these are questions I'm asking myself. Is the baby a term baby? Or does the person think that they're near term? Do they have good tone? So are they kind of like crunched up and able to have that tone, or are they just this big floppy noodle? Are they breathing? And are they crying? If your answer is yes to all those things, warm the baby, dry the baby, and you can not worry too much. If they're not doing these things, then you're moving on to stimulation and actual, thinking about neonatal resuscitation. And then you have the objective measure of the APGAR scores, which involve the appearance of the child, pulse, whether or not they kind of grimace and cry, their level of activity, and then their breathing. And those scores, this patient was 10 out of 10 both times. If their arms and legs are blue, they get a point off. That's not a big deal. But you do have this as an objective measurement if you want it. And then before we talk about kind of what the team did, we talk about kind of what the benefits are of having the baby with the mom. So keeping baby with mom calms the baby, relaxes mom and baby, actually helps physiologically with the transition to newborn life, regulates the heart rate, regulates the breathing, stimulates interest in breastfeeding, regulates temperature, improves oxygen, decreases stress, decreases cortisol. Basically, there's amazing benefits of keeping baby with mom, and actually having baby on mom skin to skin. Okay. Now I have to balance that with sort of the safety of the situation. And so the protocol wise, all we have is that we recommend that babies and mothers go to the same hospital whenever possible. Again, so that you can increase the chances that this baby is actually going to get time with mom and vice versa. When it comes to like how to get the baby there, I think it sounds like this was a good discussion on the scene, right? If you really have concerns about the mom's ability to safely hold that baby, if you feel like you're going to be needing to intervene on mom while she's in the back of the ambulance, and you don't want to be kind of disrupting or worrying about the safety of the infant at the same time, then I think there are very reasonable reasons to transport them separately, but ending up in the same place. If the mom's okay and the baby can stay on her chest and go with her, then I think that is absolutely a viable option. But what I would encourage you guys to do, which hopefully happened in this case, is speak up if you have concerns, have good communication, respectful communication with each other, and just talk about the risks and benefits, right? Like, we're a little bit in no man's land around some of these decisions, and you got to make the best choice you can in that moment. And the baby and the mom ended up in the same place and were able to be together. And that's what, in the end, what is really most helpful. So that's all I got.
Of note that baby did get transferred down to children's,
Yeah.
because apparently on birth fell and hit its head. So,
Oh.
got transported down to children's for eval by a neurosurgery.
Upon birth, you said it fell in his head?
Did they say what the birth story was? Like, was Shane
Yeah.
on the edge of a bed?
I'll read it to you here.
Yeah.
So it said, no,
Right
the delivery was home alone with her older child, dad was at work. Baby fell on the floor at delivery as mom was walking out of the bathroom. Mother thinks she hit her head on the floor at delivery, baby started crying, she didn't swaddle baby. Then they called 911.
Okay. So fall from 2.5 feet, I suppose. Cool. Any other questions, comments, concerns?
Nice job, thank you.
Thank you all.
Yeah, so. All your words are up there and you messed up.
Yeah. Are they all? Yeah, yeah.